Okay, now we will talk about the diagnostic studies in patient with cardiac tamponade. Diagnostic studies. And these studies will confirm or point towards is there tamponade or not. And then we will later on talk about the lab work which we have to look for the underlying cause. Right? Now in diagnostic studies, here the gold standard is echocardiography. That is echocardiography. As I told you in the beginning that true diagnosis of cardiac tamponade is clinical, but you can confirm or reject the clinical diagnosis by the echocardiography. Now echocardiography, there can be basically two types, there are transthoracic echocardiography and there can be transesophageal echocardiography. And when you are doing transthoracic echocardiography, again there can be two types of echocardiography, that there can be, yes, two-dimensional, 2D findings and Doppler. I don't know what are the real spellings of Doppler. This is double P. Oh my God, people are happy with one P. D or double P? L? ER, Doppler echocardiography or Doppler ultrasound. Okay. So now, really it's very easy to talk about this because we have talked about basic problems or changes, hemodynamic changes and abnormal movement of different components of the heart, right? Those will be discovered on this, right? Let me tell you, as we talked about previously, that what happens to the heart during this situation, cardiac tamponade, right? So we can talk about like this. Suppose this is your heart and here is your cable system. Right? Now what findings you can find on two-dimensional echocardiography? Very simple. As I told you, there is fluid around it in the pericardial sac and there is pressure in the fluid, and I told you tamponade develop when pressure in the pericardial fluid become more than the filling pressure in the ventricles or the cardiac chambers. Then of course what really happens, that tamponade develop. Now we should really look at the interaction of pericardial fluid pressure and the cardiac chamber pressure during diastole. During diastole, when left ventricle is, right ventricle and atria, they are relaxed. Now what really happens, that this fluid which is all around here, now this fluid, this is compressing. Of course, it's compressing the right ventricle and also compressing the, you can say, right atrium and also compressing right atrium, right ventricle, left ventricle and left atrium. But as you know, right-sided chambers are low pressure chambers and left-sided chambers are higher pressure chamber. So which chambers can be collapsed easily by external pressure? Right-sided. There's no need to remember. What is tamponade? Fluid accumulation in pericardial sac with high pressure, and this pressure should be enough to compress the ventricular, impede the or obstruct the ventricular filling, right? So right-sided chambers will be compressed more easily by this pressure. So what you really see is right atrial collapse and right ventricular collapse, especially during, yes, during what? During diastole, right? During diastole, right? This is a collapse and here is the collapse. So first feature we can say like that, one by one we talk about. That first thing we start from here. This is the first finding. What is this? Right atrial diastolic collapse. Collapse. During diastole, when pressure low is here, pericardial pressure will push it in, or diastolic compression. Number 2, this is the feature. What is this? Right ventricular diastolic collapse or compression. Is it difficult to understand? Number 3, when it is too much compressed, right, and during diastole it cannot move outward, what will happen to the septum? Right? So third finding will be exaggerated, what is this? Or abnormal motion of interventricular septum. So abnormal motion of interventricular septum. Is that right? Do you think you need to remember, or it's easy to understand? So easy to understand. As you know, if someone kick your head, it will be compressed if it's enough. In the same way, there's a pressure here, and eventually pressure there. There's no need to remember it. And then do you think, because these areas are compressed, inferior vena cava can push the blood here? No. So what will happen to inferior vena cava? It will be distended and swollen with the blood. So there will be inferior vena cava plethora. Plethora means too much abundant blood or excessive blood, or we can say dilated inferior vena cava. Am I right? What is this finding? Dilated inferior vena cava. You may be thinking, why not superior vena cava? Gravity assists the superior vena cava work. Gravity is opposing the inferior vena cava, so it's more distended than the superior vena cava, right? So this is distended. Am I clear? With that, a very classical feature here is, normally during inspiration, I told you that blood very rapidly empties into normal right heart. In normal person, during inspiration, caval blood rapidly enters into right side. So during inspiration in a normal person, inferior vena cava collapses or its size becomes slightly less. But in these cases where there is tamponade, right, during inspiration, even though the filling to the right side is more than expiration, but still it's not enough to truly collapse it or significantly reduce its diameter. So we can say that during inspiration, there is no collapse of inferior vena cava on 2D echocardiography. But again, no need to memorize it. It's very simple, right? That there's fluid around the heart. It is compressing it. Right-sided chambers are low-pressure chambers. So during diastole, they are compressed more. So atrial compression is diastolic compression. Right ventricular diastolic compression with the septal abnormal motion, and inferior vena cava dilation, and which fail to collapse significantly during inspiration. Then, if fluid is really too much, not in case of acute, but in chronic cases, when the fluid is really too much, a heart will be dangling into or swinging into this cavity, usually dangling anteroposteriorly, right? I'm not doing any, I'm just trying to tell about the heart, that this heart is not properly fixated anatomically at its own place because it is surrounded by fluid filled cavity. So it starts freely floating into that fluid. The word which is used, it's a swinging heart. I'm not talking about swinger's heart. That's a different thing. This is swinging heart, and this is only seen when there's significant effusion. So actually this swinging heart anteroposteriorly can also be noted in what? Two-dimensional echocardiography, right? Swinging heart. So these are 2D findings. Now we come to the Doppler findings. You know, Doppler actually tell about the blood flow, right? Doppler will tell you about the blood flow or different, how the blood is moving through different chambers, especially across the valves, right? So let me make another diagram. What you will see in Doppler echocardiography. These findings are 2D echocardiography findings. Now what are the Doppler's echocardiography? Now it's, let me draw the diagrams. This is on the right side. And here it is. Of course, the blood here is coming from where? From pulmonary veins. Now, it's very easy to understand. First go to the normal and then we go to the abnormal. That as I told you, normal person even during inspiration, right heart overfills and left heart underfills. This is normal. But this normal phenomenon in pericardial tamponade is exaggerated. As I told you, in pericardial tamponade, this normal phenomenon is exaggerated and right heart overfilled and left heart underfills. Is that right? Now, listen carefully. In right heart, blood has to pass through which areas? What is this valve? Tricuspid valve. And then what is this valve? Pulmonary valve. In left heart, blood has to pass through what is this valve? Mitral valve and then aortic valve. So these are right-sided blood flows and those are left-sided blood flows. Is that right? Now, if I say, as we discussed in previous part of the lecture, that during the inspiration, right-sided flow become exaggerated, there is overfilling and left is underfilling. So it's very natural to understand. If more blood is passing through during inspiration, if more blood is passing through tricuspid and pulmonary valve, transvalvular velocity will become slow or fast? Fast. It's so easy that if you are bringing more, even you put the water here, if you are putting more water, flow will be fast. Here you are putting less water, flow will be less. Even primary class child can understand that. So in the same way, you are, thank God you are very, very educated people, you can are intellectual people, so you don't need to remember what are the Doppler changes. You understand very well yourself what will happen in Doppler changes. During inspiration, right flows are increased, left flows are decreased. So we will say that transvalvular velocity in pulmonary valve and tricuspid valve and pulmonary valve will increase, right? So velocities on the right side will increase and velocities pulmonary venous return, mitral valve flow and aortic valve flow will decrease, and these are the Doppler findings. That's it. 2D findings, again 2D finding: atrial diastolic collapse, ventricular diastolic collapse, abnormal septal movement, yes, dilated inferior vena cava with swinging heart. Doppler finding, look at the velocities. Typically there is right inspiratory dominance, that right-sided flows are faster and left-sided flow are slow. So we say in these patients, as compared to expiration, during inspiration, tricuspid flow 40% increase. On left side, during inspiration as compared to expiration, during inspiration, mitral flow 25% decreases. So there is no need to remember this, right? So any question up to this? Now we come to transesophageal echocardiography. This is very sensitive test, right? But this is done specially when we are suspecting that either there is aortic dissection, because it can diagnose the aortic dissection also, or free wall rupture, or more importantly aortic dissection, and when there is tamponade after cardiac surgery. Now why? Because after cardiac surgery, tamponade sometimes loculated tamponade develop due to loculated accumulation of fluid, especially behind the left atrium. That's the most common site after the cardiac surgery, accumulation of the blood. And transthoracic echocardiography virtually misses it. It cannot really judge very well the fluid accumulated behind the left atrium. And post cardiac surgery, if tamponade start developing, and sometimes it is loculated fluid accumulated, which is compressing the cardiac chambers, right, then it's preferable to do transesophageal echocardiography. Is that right? So especially this is good in hemorrhagic effusions. Now we come to some other investigations, but classical investigation is echocardiography. It is very good for tamponade. You know why? Number one, echocardiography is very sensitive for tamponade. Secondly, it is very specific. right? It gives specific changes. Remember, echocardiography I didn't mention, it also shows the echo-free zone around the heart. Echo-free zone shows the fluid. It can also, in 2D, it can also show the echo-free zone around the heart. But just finding echo-free zone around the heart tells that there is pleural pericardial effusion. It does not tell there's tamponade or not. I told you every case of pericardial effusion is not tamponade. For tamponade, you have to see these things. This is showing that there is significant hemodynamic problem going on. There's significant strangulation there. Is that right? Now, some other tests. But echocardiography is a very good test because it is a sensitive test for tamponade. It is specific test. It has specific findings. It can be done on the bedside, and of course, it is non-invasive test, and it can be done rapidly, isn't it? Now we come to some other tests. For example, what you may find on ECG. On ECG, number one, features of acute pericarditis may be there, which we discussed in detail in previous lecture, that features related with acute pericarditis, that is ST segment, right concavity upward, right? Remember, as I mentioned previously, if there is ST segment elevation with what is this? MI, right? This is a sad face, it's a bad face, right? ST segment is elevated with concavity downward in myocardial infarction, transmural of course. But if ST segment is elevated in pericarditis, even ST segment is smiling. That's not as dangerous diagnosis as myocardial infarction. So ST segment elevation with PR segment depression, right? I will not go into detail of these, we have discussed already in the pericarditis lecture. But really I want to mention that voltages will be low. In ECG, they will be low. Number one is ST segment elevation, PR segment depression, then voltages on. Why the voltages are low? It's very simple, because the fluid is not conducting very well. And now I come to the real and important electrocardiographic finding, right? Which is important. That is the electrical alternance. Electrical alternance. I will tell you what it is. Actually, what really happens, that this is the fluid filled cavity, and heart is dangling into it and moving, right? Now heart is moving like this. Actually, it's so cardiac major ventricular cardiac vectors. Normally, major ventricular depolarization vector is directed downward, leftward, and backward. Is that right? Yes. Now, this cardiac vector, if heart keep on moving, this vector also keep on changing the direction, right? So naturally, let's suppose if we put the limb lead number 2, minus is here and positive is here, and positive, negative here and positive there. So what really happens if heart is like this, right, and its axes are directed towards this, then fluctuations will be amplified. But when it dangle other direction or it swings away, then vector has gone another direction, only a component of vector is along with it, so amplitude will become less. Then heart swing back and it is directed towards the electrode, so amplitude will be high, and then again it swings back and amplitude will be low. So what really happens, because heart is swinging in this fluid filled cavity, so when for any positive electrode, when it is vector is directed towards that, right, amplitude of QRS become high. When it directs slightly away, amplitude drop. So when you look at the ECG changes, you will find that let's suppose this is an ECG pattern, QRS complex. Now maybe next beat it become low amplitude, then again it may become high amplitude, so then again it will become low amplitude. Is that right? It's just like that. I'm facing to your eyes, you can see my full face, and now you see a part of it, then full face, part of it. In the same way, heart is turning its faces. You are getting it? So vector is, of course, the face here is electrical vectors, right? Sometimes you have going directly to the electrode and sometimes away. Due to this reason, beat to beat, QRS morphology or even its amplitude, it varies, right? This phenomenon can be seen not only in QRS, but it can also be seen in P wave or T wave, but it is better highlighted in amplitude of QRS wave. Is that right? This is called electrical alternance, right? This is a very important feature which tells that there is large amount of effusion and heart is swinging into that. So these are the ECG changes. Then we come to the chest X-ray. What investigations we have done up to now? Echocardiography, then we did the electrocardiography. Now we are talking about chest X-ray, what we can find in chest X-ray. Echo we have done, then we did the ECG, and now we are talking about chest X-ray. Chest X-ray, what you will find? The cardiac shadow will be enlarged if pericardial effusion is more than 250 ml. Because in very acute, now this is an important point, in very acute kind of cardiac tamponade, fluid will be just 100 ml or up to 200 ml, and this may be enough. In very rapidly developing tamponade effusion, the 100 to 200 ml fluid is enough to strangulate the heart, but that may not show a large cardiac shadow or large cardiac silhouette, right? So what really happens that in these patients, depending upon, suppose this is normal cardiac shadow, right? So this cardiac shadow will become enlarged and heart will become sort of, I don't know what kind of bottle? Flask shape or globular heart. This is globular, yeah, it can become, heart is truly not globular, cardiac shadow is globular. Your heart inside is unfortunately compressed. You are getting it? So we say there is enlarged cardiac silhouette. Is that right? Or shadow, but remember this will happen only when there is fluid is more than 250 ml, right? But one more thing, with large cardiac shadow, you always think of cardiomegaly and you should think of pulmonary edema. In pulmonary edema, lung fields are not clear, but in cardiac tamponade especially, lung fields are clear. And lung fields are usually in cardiac tamponade with enlarged cardiac shadow, lungs fields are clear, right? They are not showing all those features of pulmonary edema. Then you can do CT scan, yes, if you want to. CT scan and MRI. Advantages of these two tests are that they are good for anatomical detail, that you can see there, what is this, of course, exact amount of effusion you can see, but effusion can be seen in echo also very well. It can show you loculated effusions, and these can also show you some malignancies or some mass lesions adjacent to the pericardium. And in the end, yes, but it is less commonly done. Usually diagnosis is made before that. But if you do cardiac catheterization, the most important thing in cardiac catheterization is that all the chambers are surrounded by pericardial, yes, fluid and pressure. Is that right? So during the diastole, all chambers have the same pressure, almost same pressure. Could you get it? Because if it is just like that, you have 4 chambers and compress all of them with the same force, right? So all of them will have same pressure. So we can say that diastolic pressure, this is important because during systolic pressures vary too much, chamber to chamber. But during diastole, right, we say there is near equalization of pressures in all chambers of the heart, right? And this is what will be really pressure, that is determined by what is the pressure in pericardium. Any question up to this? Now we come to the other investigations. Other investigations are to look for underlying cause, right? Is there tuberculosis, or is there SLE, or there's myxedema or renal failure, right? These tests we have already discussed in detail when we were talking about, yes, previous lecture in acute pericarditis. So all those investigations will be applied you have to apply intelligently depending upon history and what you suspect. According to that, you will do the investigations, right? That, and of course you will, when you will do pericardiocentesis, you should not forget to send the fluid for analysis. Is that right? So those investigations I will not discuss into detail again, right? Now we move, how would you manage this case? Patient with cardiac tamponade, how you are going to manage, right? I would say that, let's suppose you have a patient with acute pericarditis with effusion. Tamponade has not yet developed. In your ward, you have a patient who is already diagnosed with acute pericarditis and patient is developing effusion, right? Actually, you should diagnose the tamponade as soon as it develops. Is that right? So what you will do, you will, of course, you will keep the patient hospitalized, or even in outpatient, if patient come with acute pericarditis and some effusion, right, you have done your test, you will immediately hospitalize the patient. So you hospitalize the patient and then monitor the patient. First step is, in case of acute pericarditis with pericardial effusion, step number 1 is hospitalization, and with that you monitor the patient. Now you will monitor for what? Of course, you are worried that patient should remain hemodynamically stable, and you keep on looking for the signs of hemodynamic deterioration. As I told you that you will monitor the pulse. Of course, patient should be on cardiac monitor on ECG, right? There's no need to tell that. And look for the back triangle. That you will repeatedly look for jugular venous pressures. You will look for what? Blood pressure, right? Repeatedly. And you will also heart sounds. So you keep on looking that jugular venous pressure is not rising and blood pressure is not falling. Of course, you will also look for pulses, paradoxes, and heart sounds are not becoming distant or muffled, or heart sounds may be already distant and muffled when there is pericardial effusion. But you have to look for these two things specifically. There should not be rising JVP with loss of Y descent, and there should not be falling blood pressure with pulses, paradoxes. If these things start appearing, tamponade is there. Am I clear? And of course, again, don't forget the pulse or the tachycardia. I told you, without tachycardia, usually tamponade is not there. Almost all tamponade have tachycardia except tamponade with mixed edema, uremia, on what drugs? Beta blockers drugs, and very terminal stage, unfortunately, right? So you'll monitor the patient, and of course you will do serial echocardiography, right? You will keep on doing serial echocardiography. Then we come to pericardiocentesis. If it really develops, then we'll go for pericardiocentesis. While before you put your needle in, you must know the tamponade is not due to aortic dissection, and you should know it is not due to rupture, what? Post MI free wall rupture. Is that right? After that, these two things you are sure not there, then you plan for pericardiocentesis. But before really I talk about pericardiocentesis, I want to tell you something very interesting. That even a very small amount of fluid is, when it is released, patient feels dramatically improved hemodynamically and even echocardiographically. The question is that if someone has, let's suppose, 500 ml fluid, and you just remove 100 ml and patient dramatically become better on hemodynamic parameter and echocardiography. Why such a small amount of aspiration of fluid can make better? It is actually volume pressure relationship. I'm going to explain now volume pressure relationship of pericardial effusion. Suppose this is pericardial effusion, and if we are measuring what is the relationship between volume and pressure, let me make a, here it is volume, progressively increasing volume, and here is the pressure. In acute case, of course, pressure will go rapidly up because it cannot stretch up. This is not linear. The relationship is not that you keep on increasing the volume in the same way it will, pressure will with the same proportion increase. No. Actually, it is curvilinear. You know what does it? Curvilinear, or it's upsloping, very steep. Initially, when pressure is increasing, sorry, initially when pericardial effusion volume is increasing, a little increase in pressure. But once it reaches to maximum stretchability and further it cannot stretch, a little increase in volume will take the pressure very high. This type of graph is called curvy linear. Of course, this is an acute case. Let's suppose if I say here it is pressure is, here the volume is suppose 200 ml and here volume is 100 ml, then it is acute case. But in chronic cases, because fluid is accumulating gradually, it keep on stretching, so a lot of volume is accumulated, and then suddenly when it cannot further, what is this, stretch, it will become like that, right? Now, the art of understanding is this, that let's suppose here pressure is, your patient is at this situation, that volume is 200 ml and pressure is, let's suppose, 20, right? But if you bring it, you move the volume, you aspirate the fluid and volume move from 200 to 100, pressure will not become 20 to 10, it become maybe 4. It became drastically down, right? So sometimes or even you just remove 50 ml here, I'm just giving an example, it is 150, so pressure from 20 become less than 10. You are understanding? In the same way in chronic cases, when you remove a small amount of fluid, right, volume has gone little from here to here. This much volume is reduced, but pressure is significantly reduced. So that is why you will really see clinically and echocardiography that when you start aspiration, even though it is advised you should aspirate as completely as possible, but usually you aspirate it slightly or small amount, patient blood pressure start going up, pulses paradoxes start disappearing, JVP start going down. Is that right? Am I clear? In the same way, if you are doing echocardiography, while you should do echocardiography before, and if you are doing echocardiography guided needle pericardiocentesis, you will really see that while you are doing aspirating the fluid, the features of echocardiography normalize. That you will see that right atrial diastolic collapse disappear, right ventricular diastolic collapse disappear, motion of interventricular septum become relatively normal, and even inferior vena cava plethora or enlargement disappear. Am I clear? So now what is pericardiocentesis? That is very simple, that this is actually with a needle, usually 18 to 22 gauge needle, we aspirate the fluid. What we do, remember before aspirating the fluid, you must put the patient on IV line, preferably on saline or dextran, or depending upon his volumic situation, right? Because we should give the saline. Why? We are trying to prevent the diastolic collapses, right? So anyway, so before doing pericardiocentesis, get IV line access, put the saline, arrange some blood cross match if there's enough time, and usually there's not enough time if patient is really very advanced. Then you can choose the approach. You can go subxified or apical or parasternal, depending upon your experience, depending upon the localization of fluid. You will keep the patient on 45 angle, and I'm not going into detail of procedure, right? But basic principle is that you will take 18 to 22 gauge needle, push, if you choose for subxified, which is most commonly used, you direct it at about 45 angle with the skin, and needle should point towards the left shoulder, right? And then you start, as soon as you reach to pericardial cavity, you start aspirating the fluid. But important point is that you keep an eye, rather both eyes, on this fact that you may not be injuring the myocardium. Is that right? Of course, patient is on the cardiac monitor, and on ECG, myocardial injury changes, if they appear, it means you are messing up with the myocardium, right? So usually these needles, when you pass, they should be guided echocardiographically or fluoroscopically. So you really know where you are putting your, what is that? Needle, right? So you'll aspirate the fluid as much you can, and after that, it's always wise to leave a multi-hold catheter, pigtail catheter or multi-hole catheter, so that fluid keep on draining, right, for few days. And when further draining become, of course with the time, if patient is getting better and you are treating the underlying cause also, then further drainage will become less. And when lesser fluid is coming or very less fluid come, you can pull out the drain also, right? So this is what is the basic things you do in pericardiocentesis. But remember one thing, if there is hemorrhagic fluid, it should be dark colored and it should not clot, please. If it is bright colored and it clots, you are doing something very wrong. Because usually if it is hemorrhagic fluid, then it should be dark colored. It means it is deoxygenated blood there, and it should not be clotting. It shouldn't have clotting factors like a fresh blood. But if you are bringing a fresh blood out and this is bright red and well oxygenated looking, and with that there is, you can say it clots also, believe me, there's something drastically going wrong, right? After that, then in those cases where there is recurrent tamponade, that you drain and again it comes. So those cases where there is recurrent tamponade, you cannot keep on aspirating, because sometimes you are not there to aspirate and tamponade develop and kill the person. Then you have to be taken some more serious approach. If there